Welcome to the Hearing Horizons podcast. This is Melanie Hamilton-Basich, Chief Editor of the Hearing Review. I'm joined today by Angela Bonino, Ph.D., a clinically trained pediatric audiologist who is an assistant professor in the Department of Hearing and Speech Sciences at Vanderbilt University Medical Center and Vanderbilt University School of Medicine, as well as director of the school's Children's Auditory Perception Laboratory. We're going to discuss her research on the lack of access to adequate hearing assessments for children with developmental disabilities and what could be learned from the findings to improve pediatric hearing care. Thank you for being here today, Angela.
Thank you. It's a pleasure to be here with you.
The study, which you conducted with Deborah Mood and Mary Dietrich, focused on 4 developmental disabilities that co-occur with reduced hearing: cerebral palsy, Down syndrome, autism, and intellectual disability. How many children are we talking about here? How widespread is this issue based on your research?
Yeah, so in this particular study, we have access to about 131,000 children who are being seen at 3 clinical sites in the United States. So these are larger academic medical facilities. So they specifically are Children's Hospital of Philadelphia, Vanderbilt University Medical Center, and Boston Children's Hospital. And what we see within our sample of children who are receiving clinical services at these sites is about 10% of children in our sample have one of those developmental disabilities that we're considering. So that gives us a sample of almost 13,000 children who have developmental disabilities that we're looking at. Autism is the most common of the 4 conditions for what we're seeing. And then in terms of thinking about how often does reduced hearing happen within children who have developmental disabilities, we know from previous literature that children with cerebral palsy, Down syndrome, and intellectual disabilities have a higher rate of having reduced hearing than what we see in the general population. And in our study specifically, children with cerebral palsy and Down syndrome were twice as likely as children in the comparison group to have reduced hearing than in our comparison group.
Okay, now then before we launch into talking more about the study findings and how they can inform pediatric hearing care, can you discuss what you mean when you say developmental disability versus, say, developmental delay?
Sure. And so when we're thinking about development, we're thinking about the development that happens across the major developmental domains. So cognition, social emotional, communication, motor, sensory. And so when we think about developmental disability, that specifically means that a developmental delay in one or more domain happens and starts early in childhood, and it's expected to persist throughout the lifespan of the individual. So autism, cerebral palsy are examples of developmental disabilities. Developmental delay also affects one or more developmental domains, also has early onset, but the difference is the thought is either with time or with intervention, the developmental delay is expected to resolve. Now, a lot of times we don't know for particular, depending on the circumstances that the child is experiencing. And so what you oftentimes will see is when developmental delays persist into early school age, the school age years, then the child gets reclassified as having a developmental disability.
Why is it so important for hearing care professionals to focus on the gold standard of hearing assessment for young patients with developmental disabilities? And what do you mean by gold standard?
Yeah, great question. So based on our clinical guidelines, the audiogram or behavioral testing is considered the most reliable source of hearing data. Now, auditory brainstem response, or ABR, is also considered a gold standard for infants or for other individuals who can't perform behavioral testing. Those are the only 2 assessments that we can actually use the data to fit a hearing aid. So when it comes to actually managing reduced hearing in individuals, we need to have either audiogram or ABR thresholds to fit a hearing aid, as well as to determine eligibility for special education services or early intervention services. And most states in the United States is going to require you to have either ABR or audiogram results. So we're really focusing in on those 2 particular assessments because we know they're critical as to access intervention services and supports.
Can you describe the differences in access to gold standard assessments that you saw for children with developmental disabilities in your study?
Yeah, so we specifically looked at the first 3 months of hearing health care at these locations. So in order to do that, what we do is we're working with the raw clinical data. So we look to see, is tympanometry performed, is acoustic emissions, OAEs performed, acoustic reflexes, behavioral testing resulting in audiogram thresholds in ABR. And so we're in speech testing. So those are the raw clinical data we have access to. We look to see the earliest time point where one of those results are recorded within the medical record, and then we allow information to build up over the next 3 months. And so that's what we're looking at. And then what we're establishing in terms of saying, was a gold standard assessment accessed, is that at least one threshold, whether audiogram or ABR, has to be recorded into the medical record. So we're not looking at if testing was attempted, we're looking at was it accessed. And so was the results that you would need, some level of results actually obtained on one of those measures. And so what we see, and if in the actual paper, we separate out based on the number of children who are getting access to audiogram versus ABR versus both versus neither. And for purposes of today, I'll largely just focus on the neither category. Okay. And so for children in the comparison group, so these are children who don't have any of those 4 developmental disabilities in their medical record. What we see is that about 9% of children in the comparison group don't get access to either audiogram or ABR in the first 3 months of hearing health care. In contrast, for the children with a developmental disability diagnosis in their medical record, we see 24% of children are not getting access in the first 3 months of hearing health care to one of those tests. We then build statistical models that compute relative risk, and we adjust for differences based on site, the age at the time of the first encounter, race, ethnicity, and sex, because we know that those factors can also contribute to the likelihood of getting access to a gold standard assessment. So we've accounted for those within our statistical models when we compute our relative risk. So to summarize those findings, what we're seeing is that broadly, when we define children with developmental disabilities, we see that they're 4 times more likely not to get access to a gold standard relative to the comparison group. Children who have 2 or more developmental diagnoses, so of the 4 diagnoses that we considered, if they have 2 or more of those, their relative risk is actually the highest of the subgroups that we looked at. So they're 13 times more likely not to get access in the first 3 months of hearing health care. For that particular group. Then we also then see differences for looking at the 4 specific developmental disabilities. So children with autism have a 3-fold increase, where children with cerebral palsy have a 10-fold increase, children with Down syndrome have a 6-fold increase, and then children with intellectual disability have an 11-fold increase, again, all relative to children in the comparison group.
Okay, and there were differences across the 4 different developmental disabilities you looked at. Did you want to talk a bit more about that in particular?
Yeah, so I think that's an interesting thing to be thinking about, like what might be driving some of these differences that we're seeing based on the developmental disability. And I do want to couch that we know what their developmental disability diagnosis is in their medical record, but we don't have a real comprehensive view of what their developmental profile might look like. And there might be certain characteristics of their developmental profile that are misaligned with behavioral testing assumptions in particular. It could also be that some of these children may have more complex medical profiles, and that may be driving some factors, especially when we start thinking about access to ABR testing. They may just have contraindicators in terms of thinking about sedation if they're needing to be evaluated outside of the time period where we do sleep ABR in younger infants. And so I think there's a variety of factors to be thinking about. And I think one thing that's really of interest is to recognize that a lot of children do have multiple developmental disabilities, and this particular population is at high risk for not getting access to gold standard testing, which could then result in not getting timely diagnosis of their reduced hearing, which is going to potentially compound other developmental challenges the child's experiencing and result in potentially poor developmental outcomes because they're not getting timely support around their reduced hearing.
So what are some of the main barriers to better hearing assessment access for children with developmental disabilities?
Yeah, I think there's a lot of things to think about, and I think our particular study didn't directly measure factors or barriers or facilitators, and so I do want to couch this that we're drawing on what's been published in the literature and certainly what other clinicians and parents have also discussed with us. But I think it's likely a multifaceted reason for some of the challenges that are happening. One of the two things that I just previously mentioned, I think that are really important, is the misalignments of the developmental and medical profile of these children with what our assumptions are for our testing. So behavioral testing, for example, really does assume typical development across a variety of domains. Now, our guidelines always talk about picking the test method that's developmentally aligned with the child, but the challenge is all of our methods still assume relatively uniform development across and within developmental domains, and that really can be at odds with what we commonly see in many of these developmental disability profiles. So it's it can be a common profile within autism that a child might have areas of their cognition that are actually very much so a strength for them, but then they have other areas like executive function and shifting of attention that can be very challenging for them. But our methods really assume a pretty uniform cognitive profile, as well as then considering other domains too. And so I think that misalignment can happen with what our assumptions are for the testing. I think that is really important to consider. There certainly has also been a lot of discussion within the broader healthcare field, thinking about disability-based discrimination that children and their families can experience. And I think that that's important to be thinking about too, and what might be some of the perceptions and experiences that are that these individuals are routinely encountering within the healthcare field more broadly. I think there's also challenges around the training that some audiologists may have and their comfort level with sometimes within the context of pediatrics and then specific developmental disabilities. Now, the sites we're using are facilities that have high expertise in pediatric audiology and have expertise within developmental disabilities oftentimes. But that can obviously, depending on the practice it would be thinking about, might be a factor that's going on as well. So those are just some of the examples to be thinking about that may be contributing to some of these disparities that we're seeing.
Could you talk now about what hearing care professionals can do to improve access to hearing assessments for children with developmental disabilities, especially with some of what you were talking about in mind?
Yeah, I think one thing to acknowledge is that there's a tremendous amount of research that needs to be done to help give practitioners better tools and better guidance around what can be done. So I do want to recognize that practicing audiologists are in a tricky position because there's not really great guidance that's specifically tailored to children who have developmental disabilities, and especially when we start talking about very specific developmental disability conditions.
Right.
And that makes it really challenging to do their job. And even a lot of our literature that we have around newborn hearing screening and early intervention and language outcomes, a lot of times children with developmental disabilities are excluded from that research base. Now, one thing I can tell our audiologists that I think is always important to remind them is that we all know that early intervention is really important. And we often talk about the 1-3-6. In many states have started moving even to the 1-2-3 model of screen by 1 month, get a diagnosis by 3 months, and then start intervention by 6 months for when we talk about the newborn hearing screening process. We know based on that data that achieving the 1-3-6 benchmarks results in better language and developmental outcomes. And that is true for children who have co-occurring developmental disabilities as well. And so hitting those benchmarks is really important. And I think that we all should be motivated to make sure we're continuing to hit those benchmarks and having early diagnosis, even when we're talking about kids who might show up in the clinic at age 3, age 4, age 10 years of age, and well outside of that newborn period. But because that is a really common experience. And I think that's one thing our study also emphasizes, is that the median age of the first encounter is 3 years within these clinical samples. And so even though we oftentimes really think about our newborns, we also need to think about our toddlers and preschoolers, early school age kids, and how we're going to make sure we promote timely diagnosis and access to the appropriate supports to facilitate developmental outcomes for these kids.
And I think especially before school, that would be helpful as well.
Exactly.
So current guidelines from the Joint Commission on Infant Hearing call for waiting until 9 months of age to conduct a full hearing assessment for most infants with a risk factor, but who pass their newborn hearing screening. But in your article, you and your co-authors argued that it's important for infants with Down syndrome and cerebral palsy in particular to get a full diagnostic hearing assessment in the first 3 months of life, even if they pass their newborn hearing screening. So why is that? Why is that so important?
Yeah, so the most recent JCIH, the Joint Commission on Infant Hearing position statement, was published in 2019. There have been a handful of studies that have been published since then that are adding to this evidence base. And so specifically, those other studies have looked at children with Down syndrome, craniofacial differences, including cleft lip and palate, as well as syndromes that have a high likelihood of having hearing loss. So they talk about Charge and Bohr in that paper. And what these different papers have largely argued and supported with their clinical data is that we know these children are really at high risk for having permanent reduced hearing, and to go ahead and move on with the full diagnostic evaluation, even if by chance they did pass a screener, which is obviously, depending on the instrument that they were screened with, is a broad screening tool. And so to go ahead and move forward with a diagnostic tool, especially in terms of those children who are likely to have conductive pathology, to make sure that we're including air conduction as well as bone conduction, and to be testing at multiple frequencies. And the idea here is that we get a full diagnostic, because many of those kids, in fact, will show reduced hearing on the full diagnostic ABR, even if they passed their newborn hearing screening. And I also think even for those babies who do show typical hearing at, let's say, 3 months or 4 months of age on that sleep ABR, it's really important baseline information, because especially for those children that are a high likelihood for having delayed developmental milestones, if we wait to see them at 9 or 10 months of age, as the current recommendations say, we're at a time period where now behavioral testing is what we're trying to rely on, but they may not have the developmental abilities yet to perform behavioral testing. And then some populations, like children with Down syndrome in particular, are oftentimes at increased risk for heart and breathing differences, and most anesthesiologists are not going to sign off on sedating for an ABR alone within this high-risk population during that infancy time period. And so if we go ahead and shift into thinking about these children who are really at high risk for reduced hearing into a time period where we can do natural sleep ABR, we can get really rich information on these children that can be used either for managing and diagnosing reduced hearing, or providing really comprehensive baseline information that can then be used to continue to monitor during this time period where we enter into it may be challenging with our current behavioral methods to get good results, and we may not be able to look at sedated ABR yet. Children with cerebral palsy, the research base isn't as strong for the guidelines specifically with this population, but we do see a really even in our study, we're seeing that group is at high risk for having reduced hearing compared to children in our comparison group, which is still a high-risk clinical sample. And we're seeing high risk for them not getting access to gold standard testing. And so I think more work needs to be done to know for sure if there's compelling evidence for thinking and to support the recommendation of doing a sleep ABR in the first 3 months, but I certainly think it's worth looking at, and I think it's worth thinking about designing some solid research studies looking at this issue. And it may be that it's certain subsets of children with cerebral palsy. So it may be that based on particular medical factors, those children need certain testing. Cerebral palsy is a really interesting to be thinking about, because there are a variety of factors that can be associated with cerebral palsy. So it can include things like lack of oxygen during the birthing process. But it can also, a lot of children have cerebral palsy because of congenital cytomegalovirus exposure in utero. And those are going to result in very different hearing profiles, and needing to collect information at different time periods and different types of information. So I think really thinking through this population in particular, I think is really important to make sure that we're performing the assessments that are needed to best and quickly determine what their hearing profile is, and making sure that it's happening at the time periods where it needs to happen based on their potential etiologies of a reduced hearing.
It sounds like it can be difficult to make sure that you get into that window to do the testing that's needed for, different children for their different needs. Do you think it's time for audiologists and other HCPs to look at changing the standard of care for all children so they can provide hearing assessments that will apply to a broader range of children and they can benefit regardless of their needs?
I think it is well time for us to have solid clinical trials, pragmatic trials that are pushing into clinic to really be thinking about how do we make a more expansive toolkit for pediatric audiologists to facilitate testing, and starting to collect evidence that supports usage of developmentally informed strategies that can, we think, help support testing, and to start building that evidence base around what care could look like when we step back and really focus on how do we make this care inclusive. I think the challenge is a lot of the practices and methods that we use in pediatric audiology really make a lot of assumptions around development, and the assumption around the child having typical development or having typical health profiles. And the reality is, because of the high survival rates that we have within our NICU graduates, a lot of the other, as we have shifting etiologies for what reduced hearing and who we're monitoring, we need to make sure that our practices also evolve to reflect our common patients that we're seeing, and that we have really good tools for clinical audiologists to use. And I think it's thinking everything from how can we either redesign our current test methods or evolve into more inclusive test methods, but also thinking about even simple things like scheduling. Like, how do children who have developmental disabilities benefit from a longer test session? And how do we work with our schedulers to make that happen at our sites? What does reimbursement look like, right? So I think there's just a lot of factors to think about. We have a lot of concern that even when those children do get access to gold standard testing, the amount of thresholds that are collected in a test session may be less than for a child who's typically developing of the same age. And so how do we have robust support structures to make sure that that child gets in quickly to finish that testing, so it doesn't become a 9-month process to get a full audiogram and to move on with hearing aids if that's what needs to happen for that child, but in fact that we're able to get them back in quickly, get the audio, and be able to move on for that child in a way that still allows us to hit these benchmarks when we think about this 136 framework, and if we're applying it to older children. But how do we go ahead and build those systems and have the right types of training for our providers, so that families and children can move through the system and get to a timely diagnosis and access to supports?
Yeah, those are some really good points. So if children with different developmental disabilities require different approaches for the best hearing assessment, how do you know who needs which types of tests or testing strategies? Is it always clear from a child's records, say, what would be the best approach versus, standard type of assessment?
Yeah, that's a really interesting question. So we have some additional work that we're working on right now. That's a different paper that's under review, And one of the things that we specifically are looking at is what's the probability that audiologists would know that a child has a particular developmental disability based on the age in which they're coming into audiology. And what we see in that study is it largely mirrors what we also know based on the published literature in terms of age of diagnosis for these different developmental disabilities. So, for example, we know that autism is often diagnosed around age 3, age 4 years of age. Intellectual disability is often quite a bit later. So oftentimes those children are 8, 9, 10 years of age before they'll formally get an intellectual disability diagnosis in their medical record. And a lot of that has to do with just the challenges and the demands of the testing protocol that they need to complete. So those children may have a global developmental delay diagnosis or delayed milestones, or it may be that they're being monitored for that, but they don't have the formal diagnosis of intellectual disability until they're well into the school age years. Other things like Down syndrome and other chromosomal abnormalities oftentimes are diagnosed pretty early. So most Down syndrome diagnoses are often given prior to the first birthday. So it's really going to depend on what is the odds an individual is going to be able to determine if a child has a developmental disability just by looking at what's already available in the child's medical record based on the child's age and the suspected developmental disability. And so because of that concern, I do think it's worth thinking about developmentally informed strategies that we can go ahead and start incorporating into clinical care and have that being standard practice rather than things being like a one-off where you have a fail-based model where a child can't perform a task. And now, when you come back in 2 months from now, then we'll add in these extra tools. So in the literature on developmental disabilities, there are a variety of evidence-based strategies that are well known to support children when they're learning new tasks, when they're engaged in different types of intervention, when they're engaged in school setting or work setting. Some of it's been done in medical environments, but not as commonly. But we know things like providing picture schedules and video models can be really helpful ways, especially for individuals with autism, but with other developmental disabilities as well, to learn a new task. This also helps break down the task visually and helps you check off or move the item when you've completed and finished that item. And our speech language pathology colleagues use these types of strategies on a routine basis, and many audiology practices aren't using it yet. Some are. Similar social stories or a similar type of support structure. So we can be thinking about those types of things. Also thinking really carefully about the reinforcement that we use, especially for those children who are being tested with visually reinforced audiometry. Oftentimes our booths have mechanical toys or video clips that we're sharing, but we know that if those materials are aligned with the child's interest, we typically are going to see more trials out of the child. So we might have a 13-year-old who comes in and visually reinforced audiometry is the most developmentally appropriate of the three methods in terms of VRA versus condition play audiometry versus conventional. But they're really interested in race cars or athletes or something, right? And so they're not going to be motivated by a dog barking in a plexiglass box. And so I think that's really important to think about how can we tailor our reinforcement based on what the child's interested in so that it's more meaningful and more engaging for the child. And so that's just a few examples of thinking about ways that we might be able to get some of this information up front from parents and from the child, as well as thinking about ways that maybe we can implement them just as standard care across the board for all of our patients, because it very likely is going to be helpful for other children who are typically developing, especially our 2 to 3-year-olds, who oftentimes can be ages where we struggle with some of our current clinical methods to get really robust and reliable results. And so that's another way to improve care.
Yeah, those are some great ideas. Thank you for providing those examples. How important is it for hearing care professionals to collaborate with other medical professionals, such as a child's pediatrician, to make sure they continue to receive the ongoing care they need? And what does that look like?
I think that's really important for us to think about, and for audiologists to step back and really understand who their partners and what their pathways of referral and care look like within their particular organization, and to strengthen those alliances and communication streams so that there's really clear understanding of when children should be coming in. If the findings were incomplete, why is it important for the child to come back? Because oftentimes the pediatrician is going to be the person who's interfacing the most with these families. And we need to have buy-in of the pediatrician for what we're doing as audiologists, and why hearing is important, why there might be that we need a child to come back to finish getting a full testing, and for the help with the pediatrician to set up expectations around the fact that given a child's age or developmental profile, it may be pretty likely up front that this may take multiple visits. And I think to be able to communicate that up front and set expectations with the family is really important, and then to continue to make sure that those referrals are happening, and that there's clear partnership. I also think it's really a helpful skill to develop as our trainees in audiology or our current audiologists, to make sure that they're effectively communicating around developmental concerns. Obviously, it is not within our scope of practice as an audiologist to diagnose a developmental disability, but it is well within our scope to screen and to make observations around developmental profiles. And so I do think there's an opportunity to making sure that we're communicating clearly with the pediatrician that during our behavioral assessment appointment, we saw behaviors that are red flags for autism, for example, and that we were really encouraging and discussed with the family that yes, their hearing is typical, but yes, we also saw all other behaviors that might suggest a further developmental workup is needed, and that they need to continue and engage in that conversation with the pediatrician. And so I think there is an opportunity here for audiologists to get more training on developmental disabilities, so they're more comfortable having that conversation and building that alliance with pediatricians and other specialty care in terms of developmental pediatrics, to help make these referrals, and or at least to have a point in a consultation. Because I also think the other thing that happens too is for our children who are in fact deaf and hard of hearing, audiologists can be in a really unique position to help provide some level of insight if the types of behavioral or developmental differences that are being observed are or are not consistent with a child's hearing profile. And so I think to also work within a multidisciplinary team, but to help with that information when it's clear you're seeing behavior that isn't expected based on that child's hearing profile, so that the team doesn't contribute that behavior to the hearing loss alone, because the other team members may not have expertise in reduced hearing.
Well, that's a great point. Are there further resources you recommend for hearing care professionals interested in learning more about your research and how to better address children's various needs during hearing assessment and for ongoing hearing health care?
So we have this paper that's coming out. Hopefully we will have a few more that are in the review process right now that will better describe some things. And then I have done training through Hearing First that will move to like a asynchronous, I forget exactly what they call it, but essentially like it'll be available for folks to log in and do when they want to do it. And so that will be an option. And then there are, I'm trying to think what else was a good example for you. Yeah, so I think, okay, so let me try and give you a better answer here. So in terms of, if folks are interested in learning more about this topic, feel free to reach out to my group if there's any types of things that we can help provide support with, but also that there are a couple other papers that are under review from our team. And then I have done training with Hearing First that's available through their website. I will be at some other meetings and happy to talk more there. And then there are some other groups in terms of thinking more broadly about developmental disabilities, that I think for those of listeners who might be associated with larger medical centers, it's a great opportunity to reach out to your developmental disability colleagues to learn more and to think more about these partnerships and get more insight. CDC also has a training specifically for medical providers that's focused on autism. And so that's another option as well that might help folks have some broader training.
Great, thank you. Thank you for sharing your expertise and insights. And thank you to our listeners. For more Hearing Horizons podcast episodes, as well as articles, news, and more for hearing care professionals, go to hearingreview.com, where you can also subscribe to the Hearing Review and our e-newsletters. You can also find Hearing Horizons episodes wherever you get your podcasts.